Assalamu alaikum, everyone. Thank you so much for joining today's talk that will focus on the children's mental health. We've been very fortunate to have Dr. Mustafa Abdul Hussein, who is a psychiatrist, and he has been doing a lot of our mental health talks. So we're very excited to have him back on again. So without further ado, I will pass it on to Dr. Abdul Hussein.
Assalamu alaikum wa rahmatullahi wa barakatuh. Shukran, Dr. Fatima Ben, for that kind introduction. અવલન દુઆ કરું છું કે આપના ફરજંદો જે આઈંદાનો લશ્કર છે એ સગલાને ઇખલાસી તૈયાર કરનાર મૌલા આકા મૌલા આપના જાનો सी ઓલા સૈયદના અલી કદમ મુફદ્દલ સૈફુદ્દીનની ઉમર શરીફ ખુદા તાલા તા રોઝે કયામત દરાજ અને દરાજ કરે આમીન. મૌલા તૌલમા શરીફને ફરજંદોની ઘણી ફિકર હોય છે અને અક્સર સુનીએ છીએ કે મૌલા એમ દુઆ કરે છે કે એ મુમિનીન તમારા ફરજંદોમાં તમારા ફરજંદોના ફરજંદોમાં તમારા ફરજંદોના 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 ફરજંદોમાં એમ 70 પેરી લગન ઈમાન બાકી રાખે આમીન. આ દુઆ મુસ્તજાબ છે તે સબબ ઝેની અને જિસ્માની બેવેની સેહત કામિલ કેમ રાખવું એ કોશિશ આપણે કરીએ છીએ. હમણાં એમ બી અદા કરી લઉં છું કે SBMAA જે મૌલાએ બી કાયમ કીધું છે એ સગલા ખિદમત ગુજારો ઘણી મહેનત કરે છે. આખું પ્રેઝન્ટેશન આખું આ મીટિંગ એ લોકોએ પુટ ટુગેધર કરવું છે, ઓર્ગેનાઇઝ કરે છે, સ્પેશિયલી ખાસ કરીને ડૉક્ટર ફાતિમા બેન. અને હમણાં મે મેન્ટલ હેલ્થ અવેરનેસ મંથ છે તો એક હેલ્પલાઇન બી કાયમ કીધું છે જે મોહરમાત વાસ્તે તો કોન્ફિડેન્શિયલ હેલ્પલાઇન છે સગલા ઇસ્તેમાલ કરે ને ફાયદો લે. મૌલાની જે ઉમ્મીદ છે ફરજંદોના મેન્ટલ હેલ્થ અને ફિઝિકલ હેલ્થના વેલબિંગ વાસ્તે અને સ્ટેબલ રહે ये सिलसिलाમાં આજે મેં મેન્ટલ હેલ્થ ચાઇલ્ડહુડ મેન્ટલ હેલ્થના જિકરમાં ટોપિક પર જિકર કરું છું. તો મારું નામ મુસ્તફા અબ્દુલ હુસેન છે. મેં એક બે જેમ ડૉક્ટર ફાતિમા બેને કીધું એક બે પ્રેઝન્ટેશન્સ કરી ચૂક્યો છું SBMA વાસ્તે, પણ આજે ચિલ્ડ્રન મેન્ટલ હેલ્થ પર ફોકસ છે. તો મેં હમણાં ફિલહાલ અહીંયા છું, મિનિયાપોલિસમાં રહું છું અને અમારો કોન્ટેક્ટ ઇન્ફોર્મેશન છે. સોરી ડૉક્ટર ફાતિમા, કંઈ કેવું છે? Did you want to say something, Fatima?
No, no.
Sorry. तो anyways, तो मैं contact information से please note down કરી લેજો. ઇન્શાલ્લાહ मैं કોશિશ કરીશ કે થોડું at the end આજે Q&A બી રાખીએ, ટાઈમ રાખીએ, મગર ના બની શકે તો પ્લીઝ મને કોન્ટેક્ટ કરજો અને મેં કોશિશ કરીશ. તો આ ટોપિક ઇઝ વેરી વાસ્ટ. ઓબ્વિયસલી મેં એમ જ અહીંયા હમણાંથી શરૂઆતથી એમ જ કહી દઉં છું. It's like asking Dr. Fatima Ben, for example, to say, tell us about adult physical health, for example, in 45 minutes. So it's difficult, but it's complex. I know there's a lot of people that are worried about it. Parents, children, teachers, pediatricians, they're all worried about it. It's an emotional, social, behavioral, neurological topic that has a lot of impact, of course, on children. I've tried to distill it down to, I think, what I feel would be the most appropriate use of our time. ADHD, of course, is very prevalent in children. It often presents in children. Autism, emotional dysregulation disorders, social media is very important. Humna Maulana bhi farmaya hai, substance use, especially vaping. Eating disorders often starts in adolescence, so that's why I thought it'd be wise to talk about it here today. And then, of course, warning signs for more serious mental illnesses. I haven't really talked about bipolar disorder or schizophrenia. So those are topics maybe for future presentations. But also, ek topic I could probably do a half an hour, 45-minute presentation. So I'm going to try to go a little bit fast. I will try to keep it a little bit interactive. So if you're joining the meeting, then obviously please use your chat function and also the raise hand function as well. There's a few questions that I'll be asking. That would just be nice. We can try to participate as much as possible that way. The last thing I've written here is hope, and so I'm hoping to instill some hope in the sense that if we can have supportive relationships with children, and if we can catch these disorders early enough and engage children with treatment and provide the most appropriate treatment, children are remarkably resilient. So the outcomes and the prognosis is, alhamdulillah, is okay. There's hope for that. So question, please use the chat function. I can pull up the chat function here and I can see it myself. So If you had to guess, what age do you think most mental illnesses begin? And I'll just give 30 seconds for this really quick. Okay, 10 more seconds. Perfect. Shukran, Saglano. Thank you so much for everybody who participated. I appreciate that. So I'm sure you can all see the chat function, but a lot of people are saying very young ages. Some people are saying under 5, under 3, and 14. So absolutely correct. There's no exact number, but there is a fact that 20% of children will experience a mental health condition. So I'm sorry, it's a bit disappointing, I suppose. There's not an exact number. I'm not giving you, at 5 years old, mental health starts. That's not what it is. But certain mental health illnesses start earlier, and certain mental illnesses present more later. Later. Most adult psychiatric illnesses, including anxiety and depression, they do show signs in childhood. We know that early support helps long-term prognoses, and we know that the relationships that children have during their childhood, mainly family and school, are very important and critical for their development. Children who struggle with mental health struggle with learning, they struggle with relationships, they can struggle with physical health. The entire family unit's functioning can be impacted by a child who is struggling with mental health. Parents, of course, siblings, grandparents even. And again, depending on when these illnesses are caught and treated, it can affect actually long-term outcomes as well. Children are not just miniature adults. The brain is different, so therefore the mental health struggles that children have is different as well from adults. In essence, this slide is summarizing that adults are able to vocalize their distress a lot better than children. Children often have more behavioral symptoms, physical symptoms than adults. So we're talking about tantrums, we're talking about irritability, we're talking about aggression, we're talking about refusal for school. We're also talking about physical symptoms like headaches and stomach aches, for example. So that's another reason this area of psychiatry is quite complex because we're dealing with so many different factors, trying to make a diagnosis all at once. Okay. So what symptom, this is just a one-word answer, again, 30 seconds. What symptom of depression do parents miss most often? If you had to guess. And again, just type it into the chat, please. Okay. Okay, very good. Excellent. I didn't realize I was talking to such a well-versed crowd, so that's helpful. Thank you so much. But you're all correct. But the correct answer is actually irritability. So if you think about it, if you think about as a parent, right? If you have a child who's becoming more irritable, would most adults think about depression right away, or would they think maybe this is an attitude problem? If we're being honest, we might think, oh, sort of roll our eyes and say, this is a teenager and they're giving attitude and so, but irritability is a classic symptom of depression in adolescence. So that's something to take away, I hope. The thing that worries us most as practitioners, as psychiatrists, is actually lack of interest or loss of interest. We call that anhedonia. You might have heard of that term, but that's essentially all that means is loss of interest. So when a child or an adolescent is losing interest in doing the things that they wanted to do before, that's a big deal for us. It can be, it could be spending time online, spending time with friends, sports, even if it's social media. Not we'll talk about that in a little bit, but if they're not wanting to do that anymore, they're not wanting to go to school anymore, they're not wanting to do their projects or spend time that things that they had fun with before, that's a big warning sign for us. Okay. I've got some cases. These are not people that I've known. This is just these are made up cases, and I've apna mein naam nakha che just to make it more identifiable for people that we might know. That's all. That's the only reason I've done it. I don't know anybody by the name of Jamila who's 15. Okay, so Jamila is 15 years old. She's increasingly irritable. She's isolated. She's failing classes, and she's arguing constantly. Her parents are saying she's just disrespectful, and she's addicted to her phone. So one thing to take away is, how does depression look different in teens versus adults? We already kind of mentioned that in the previous slide. So the irritability is the most oftentimes the first warning sign. It's important because it looks different than in adults. In adults, if somebody is irritable, we might attribute that more to anxiety rather than depression. And it's also important because it's one of the first things that parents might notice as a change. And they might attribute that, parents might attribute that to normal, as I said, at adolescence. They might attribute it to laziness or screen addiction or oppositional behavior. But one of the things I'd like you to keep an eye out for, if you're, if you have a child in this age group, or if you're an educator, is to think about, could it be depression? હવે slide, I'm not going to go into too much detail. I know there's a lot of words on this slide, so I'm not going to talk about it too much. તમને screenshot લઈ લેવો હોય to please feel free to do that. But this is summarizing the difference between depression in children and adolescents and in adults. The left-hand side ઉપર જે બચ્ચાઓ are common things that they might present with, and then જમણી બાજુ જે મોટાઓ જે adults might present with, these are the things that they often have. Okay, Adam is 8 years old and he has frequent stomach aches every Sunday night and before school. The workups from the pediatrician are normal. He's starting to beg to stay at home, and whenever he's dropped off at school, he's really crying, and he's got tears coming down his face. So just out of raising your hands, how many people think that this is just a phase? I'm going to try to pull that up as well. Okay, thank you. So it is likely something that the child might grow out of, but it is a warning sign for anxiety. So what signs suggest anxiety rather than manipulation, for example? What if this child is trying to manipulate his parents and saying, I'm going to do this and then I won't go to school? So this is a bit harder to answer by the chat function. So his avoidance suggests that he's more anxious rather than manipulating, and it's happening every week right before school. If it was more manipulation, you might think that it's before other activities, before he's wanting to watch or whatever activities he's wanting to doing. So it's very specific to the situation and the timing. Hypothetically speaking, the parents could say, well, our child is having a tough time. He's crying before going to school. Let's keep him home. So short term, it'll be helpful. Long term, it'll be harmful, because anxiety gets better if you avoid in the short term. It gets worse if you continue to avoid in the long term. In this scenario, gradual exposure might be helpful. So gradually, maybe, and a lot of schools I think have that now, especially for children in kindergarten and first day of school. They have either the parents can accompany them, they have half-day schools before school starts. એ લોકોને સ્કૂલમાં લઈ જાય છે, દેખાડે છે કે આ classrooms છે, અહીંયા lunch cafeteria છે, gym છે, etc. And so I think that's been very helpful more recently. હવે again, આ એન્ઝાયટીના જે ફરક પડે છે ડાબી બાજુ બચ્ચાઓનું અને જમણી બાજુ મોટાઓનું. તો બચ્ચાઓ separation anxiety, avoidance is more common. Whereas in adults, excessive rumination and irritability, muscle tension, sleep disturbance, those types of symptoms are more common with anxiety. Again, the takeaway is that children don't have the words, they don't have the vocabulary, they don't have the intelligence yet. They have emotional intelligence, but not able to assign the words to those emotions to verbalize their distress. And so therefore, their distress comes out in other ways. Again, I'm just mentioning, I'm sorry, I got one slide ahead of myself, but the emotional symptoms mature earlier than the control symptoms, and executive functioning develops more gradually. Emotional regulation is learned. And here's an important point. Oftentimes, children will mirror the adults around them. So they will learn how to regulate their emotions based on the adults that they're witnessing, mostly their parents and their teachers, of course. So that's why it's important that these relationships are healthy, that we are also as parents and educators, we're mirroring healthy coping of our distress. Right. So, bachi sawal thay che ke, okay, you're talking about all these things that kids will have, but what if they have it and is that a disorder? Is that a problem? Should we get treatment for it? The main thing that you should be looking out for is time frame, how long the child has been struggling with it, how severe it is, and then where are you expecting the child to be based on their developmental age. Obviously, you can't measure a 5-year-old emotional maturity with a 10-year-old's emotional maturity. Those are very different. They have a lot of different expectations. And also, one more thing I would suggest is how many areas of that child's life are affected. Obviously, the more the child's life, the areas, home, school, sports, etc., are affected, then that's more concerning. Right. So Sarah is 13 years old. She gets good grades. She never causes problems in class, but she takes 3 to 4 hours every night to finish her homework because she's rereading directions repeatedly. She forgets what to do for her assignments and cries from feeling overwhelmed. Her parents think that she's just too anxious to focus. Again, not very amenable to the chat function, but girls have ADHD as well. They're often missed because they internalize their symptoms more than boys. Boys are thought to be more disruptive in class, blurting out answers, squirming in their seat, that sort of thing. So that's why it's not as obvious when a girl has ADHD. I just mentioned those. And then it can be ADHD and it can be anxiety. Generally, anxiety can present as anxiety, sorry, ADHD can present as anxiety, especially when it comes to school, because she's getting so overwhelmed. She's trying her best and she's not able to get the grades. That causes more performance anxiety, and then both of those things can overlap. So ADHD, I'm be very surprised if you haven't heard of it. I'm sure you've heard of it in pop culture or in passing. Many families talk about ADHD. It stands for Attention Deficit Hyperactivity Disorder. Before it used to be called ADD or Attention Deficit Disorder. Now we just clump it into this one thing called ADHD. So ADHD, it presents in different ways. It's more than just hyperactivity. It affects attention, of course. It affects executive functioning, emotions, and impulse control. Common examples are like losing things, forgetting things, emotional problems, difficulty concentrating on different tasks. And it's a disorder that many children with ADHD have, but sorry, many children have it, and they know what to do. So it's not a problem of intelligence, but they just have a problem with carrying out that task on a consistent basis. That's where the trouble lies with ADHD. Okay, there's lots of myths and a lot of facts when it comes to ADHD. Some people will say, "Okay, oh, everybody has ADHD. Oh, doc, you're diagnosing everybody with ADHD. Any child comes in and you think they have ADHD." So that's not particularly accurate, but it is accurate in saying that talks like this, for example, or raising awareness, like I mentioned, in pop culture, in TV shows, in movies, celebrities, for example, they're talking about it more. So there's more awareness for it. Teachers, I think, are much more attuned to it. I think parents are also much more attuned to it. So there's better recognition for it. So that might be why we're diagnosing it more frequently. Kids just need discipline. It's not a matter of discipline or upbringing or parents not doing something correct, because it is the way that this child's brain is functioning. Medications changes personality. This is a big one, and I want to spend just a few minutes talking about it because I think apna mano, so especially we have a reluctance with medications, and sometimes rightly so, especially bachao sate. So imagine તમે એક બચ્ચાઓને તમે જાણો છો તમારા પોતાના બચ્ચાઓ બી હોય and he or she has very severe ADHD. So all the symptoms that I'll list on the next slide, and you are recognizing that this is my child. So now imagine you treat them, and all of those symptoms of the severe ADHD now become mild, or they become moderate or mild, excuse me. So you can imagine in that scenario, okay, a lot of the things that you are assigning to this child, this is this child, now are better. So it looks like this person is different or their personality has changed, whereas those symptoms that are disruptive to them and their lives have reduced. A lot of people think, well, ADHD is a normal thing in childhood. A lot of children have it. They'll get older, they'll outgrow it. Unfortunately, they don't really outgrow it. The symptoms might change. They might become they might be more hyperactive in adulthood. And as they grow older, as an adult, they might have more inattentive symptoms, for example. So I want everybody to take away the fact that with treatment, with appropriate treatment, supports, school recommendations, therapy, medications if needed, this can be helped, and it really can improve quality of life. તો again આ એક સ્ક્રીનશોટ સ્લાઇડ છે. તો તમને લેવું હોય સ્ક્રીનશોટ, પણ આમાં ઘણું ઇન્ફોર્મેશન છે. Main thing is કે inattentive symptoms are on the left, hyperactive symptoms are on the right. You need at least 6 or more in children, 5 if you're an adult or greater than 17, and then the same on the right hand side. If you can have inattentive predominant ADHD, you can have hyperactive predominant ADHD, and of course you can have combined. Importantly, for the diagnoses, a child has to be the symptoms have to be present before 12, and we have to see at least a 6-month time frame. So it's not just 1 month. This last month, my kid has been, having difficulty sustaining attention. We want to see it for a little bit longer than that, and also more than one setting. So if it's ઘરે તો ફાઇન કરે છે, કામ બરાબર કરે છે, લેસન એનું હોમવર્ક બધું ફાઇન ટાઈમ પર કરે છે, પણ સ્કૂલમાં ટીચર્સ કહે છે કે નથી ફોકસ કરતું. So technically that wouldn't meet criteria because it has to be in 2 or more settings. So sports, the coach is always saying that whenever I'm talking, the kid is looking around and not paying attention or bouncing the ball all the time. Or at school, the teacher is saying that he's running and climbing on things and blurting out answers, butting people in the line, these types of things. And then Gare, we're talking and it looks like he's in his own world and losing items and easily distracted, not paying attention. Waramar ke upare, for example. So that would be more of a combined presentation, for example, in that scenario. Okay, this was supposed to come after. Oh, yes, it is. I'm sorry, it did come after. So એક questionnaire છે. ઘણા physicians and parents and teachers might be familiar with this. So we want to see what the rating scales are. This is just an example. This is one. This is called the Vanderbilt assessment scale. There's different types of one. There's Barker. There's the Cadra assessment scale. There's different types depending on what you're used to using, depending on what your physician is using. It's a rating scale, different scenarios, different questions, and then it's scored. Kids with ADHD will often be in the often to very often column. And sorry, one more thing about this really quickly. It's important. This is an important thing, an important tool that we use in treatment because let's say somebody had very often all the way down, and પછી dawa sharu kari, so we want to see what the effect of that dawa is over time because obviously we want those numbers to get better. Depending on the age of the child and the adolescent, you'll see more symptoms of the ADHD. So young children have more constant movement. They're sometimes unsafe, making impulsive decisions, like in the playground, for example, might injure themselves. They have difficulty waiting. And then as they get older, grades 3, 4, 5, 6, they have trouble with academics, emotional problems, and social difficulties. In adolescence, we see more procrastination, we see more risk-taking, low self-esteem and anxiety and depression. And then, as I mentioned, in adults, we have more with procrastination, time management, and emotional exhaustion, sometimes even shame for not functioning as high as they think they can or feeling like they're lazy. And it can affect, this is a serious, it can affect relationships, it can affect their parenting, employment, it can affect sleep. So there's lots of different impacts that this illness can have. Okay, Ammar is 10. His teachers say he's bright and participates in class discussions, but he never turns in homework. He loses his jackets and lunch boxes every week. He's interrupting all the time. He gets really upset when routines change. But his parents say, well, I mean, how can it be ADHD? He's using his Minecraft for 4 hours. It can't be ADHD. He's got good attention with Minecraft. So just because he's able to hyper focus, it doesn't rule out ADHD. In fact, rewarding activities like video games, especially now with a lot of the video games, bright colors, lights, sounds, they give points for doing side quests and these types of things. So those types of immediate rewards are very amenable to addiction, essentially, and keeping somebody's attention for a longer period of time. Untreated ADHD, low self-esteem, we talked about, it can affect academic performance, which can affect life outcomes, right? College acceptances, different types of college programs. It can affect jobs and salary expectations, et cetera, et cetera. So really, it can affect somebody's whole life arc. And to parents, I would say that if it's they're worried about stimulants, again, that would be something to talk to your regular doctor or primary care pediatrician about. But I would always say it depends on the risks versus benefits and the severity of the symptoms. So again, diagnostic criteria, imagine having all of those things so that you can see that that's a very severe case with a lot of different effect. So therefore, the benefits of medications might outweigh the risks. Another screenshot slide. Ganu information share slide upar. I'm not going to go into too much detail about it, but on the left-hand side is medicines, and on the right-hand side is therapies. So both are important in ADHD, as with most mental illnesses. So you might have heard of some of these medicines. You might have heard of Ritalin or Adderall or Vyvanse, gonna popular names, chip. And these are non-stimulants. So the non-stimulants and the stimulants, they just work differently, and they have different effects. They have different side effects. So the things we're monitoring are including sleep, appetite, blood pressure, heart rate, anxiety. These are the things that we're looking out for when we're treating somebody with medications. Different types of therapy, again, are very effective. They're evidence-based. There's parent management training. One specific type is parent-child interaction therapy, or PCIT. The the main idea for parent focused techniques, I'm not the expert in that, but the takeaway point for therapies is encouraging good things and positive reinforcement for things that you want to see, and then negative reinforcement or decreased attention for things you don't want to see. School-based help and programs like IEP programs, 504 plans, those are helpful. Individual therapy focusing just on the child, how to focus and how to deal with their inattention. And then, of course, school and group-based therapies are also important. Just really briefly, before I move on from treatment, there's another type of treatment that goes almost without saying, but of course I'll say it, is lifestyle treatment and diet and physical activity. Those are very, very important for patients with ADHD, especially when it comes to sleep. Sleep consistency is very important. Routine consistency is very important as well. When it comes to diet, people always wonder about sugars and, don't give them cake right before bed because they'll be hyper. There might be something to that, but avoiding dyes and preservatives, there's probably more data about that. And also omega-3 fatty acids have been, supplementation has been helpful. Iron, zinc, and vitamin deficiencies should also be ruled out. Wow. So we're just moving forward now to the next topic. I have about 20 odd minutes left. Autism is another topic that I wanted to talk about. Generally, we pick this up in childhood. So children with autism are different. They're not defective. It affects different areas of their lives, including communication, sensory sensitivities. They often need very predictable routines and predictable routines. Focused interest, they have repetitive behaviors, and they're very often very literal. Girls were historically underdiagnosed. I think it's just important to bring the fact that we should approach this with nuance and respect and a little bit more understanding. So hopefully that's what, and it also is also a spectrum. Did I mention that? Yes, I did. Yeah. So it can present from verbal. Somebody is you can't really tell. Maybe their speech might be a little bit different versus nonverbal as well. So there's a wide spectrum, autism spectrum disorders. When you compare these two illnesses that we've talked about, ADHD versus autism, there is some overlap, but they're mostly different entities. But that being said, a lot of children can struggle with both, and it's helpful to understand the differences because that helps schools and it helps families provide the appropriate support. This is something that was newly added to the DSM-5, so I thought I would mention it. It's called DMDD, or disruptive mood dysregulation disorder. I'm not going to spend too much time on it. Essentially, what it is chronic irritability, severe outbursts, more anger. And obviously, you can imagine somebody struggling with that causes a lot of suffering for the person, but also for their families and the people around them. It's not typical tantrums from hunger and sleep deprivation. It's not about bad parenting, and it's not personality disorders or bipolar disorder of childhood. Okay, another question. Hopefully, you guys are still with me. So give me a number. How many hours of sleep does the average teen actually get? Hmm. Hmm. Okay, excellent. Yeah, so the number is, I mean, technically it's not enough, but yeah, I'm seeing a lot of sixes. I would agree with 6 to 7. It's, I don't want to say it, but you know what I'm thinking about. And so the average teenager, how many hours do they typically need, according to the National Sleep Foundation? So if this is how many hours they're getting, how many hours should they be getting? 8 to 9. Okay. So of course it's going to be higher. It's 8 to 10. Right. 8 to 10 hours is the average amount that a typical teenager needs for sleep. And we're talking about regular sleep. So I'm saying that specifically because I'm, people in glass houses, but generally people are more sleep deprived during the week, school, work, and then they might make up for their sleep on the weekend, paying off the sleep debt. But in 1 day or 2 days of getting more sleep is not going to pay off 5 days worth of sleep deprivation. Let's say, for example, your brain needs 8 hours of sleep every night. And let's say your brain is getting 7 hours of good, restful sleep every night. So you're 1 hour less. Multiply that by 5. Now you're 5 hours less. Very few people are sleeping 5 hours extra on the weekend. They might sleep 2 or 3 hours extra, but again, so they're going to continuously be sleep deprived. Of course, as we get older, we need less sleep. So toddlers and preschoolers and school age children, they need more sleep, like 9 to 11 hours is the official recommendation. So that could be one reason why people are, especially children, are struggling a little bit more because sleep deprivation. I think many children, many adolescents are sleep deprived. There's definitely more of an academic pressure when we're talking about nowadays versus back in the day. There's reduced free play, constant stimulation, family stressors, social comparisons, and online life. These are all different factors that are affecting children today in modern life. And a lot of these things, evolution and upbringings, they don't adapt to these things, of course. So I'm not pointing fingers. I'm not saying schools. I'm not saying parents. I'm not saying anything like that. I'm just giving an idea of why maybe more children are having mental illness struggles now. So social media, like I mentioned in the last slide, so social comparisons, online life. Just by raising your hands, can you tell me how many parents think that their child is spending too much time on social media? Yeah, I'm gonna cut it short there because I'm gonna run out of time, but I'm gonna go ahead and assume that almost every parent is going to be worried about that at some level. So social media and the adolescent brain. Adolescents are really sensitive to peer approval. They're sensitive to social comparisons and status, and also being excluded from groups or news or they're talking about it. I don't know about it. They're really sensitive to that sort of phenomenon, and social media unfortunately really amplifies all four of those things. And then there's one word, there's an A word that I'd like to think about, but it's actually here. The second point here, it's algorithms. So I don't know if any of you use YouTube, but I do use YouTube from time to time, and I noticed the algorithm even suggests so many things, and it keeps suggesting videos that I've watched, of course, because the algorithm figures, well, this person is watching these videos, and so of course we should suggest more videos like it, and that causes the person to spend more time on that device, on that app, on that website, and it's very powerful. And that's a very new phenomenon. I mean, I think we can all agree that 10, 15, 20 years ago, that wasn't a thing. And so now there's governments that are wising up to this. You've probably read in the news, Australia, the EU, the UK, they all have safeguards in place for adolescents, age verifications. I think there was an article about adolescents in Australia putting a fake mustache on, trying to get past these algorithms, but or these safeguards. But anyways, the governments are trying to. There's obviously concerns about cyberbullying and misinformation, and so there are quite a few concerns with social media. There is an association with anxiety and depression. When I last looked this up, there was a study that showed that if a person has more than three social media accounts, on the previous slide, I showed you all the icons of the different social media. So if you have more than three, the risk of depression goes up by 30%. So, the more social media accounts you have, of course, the higher the risk. It affects sleep, especially if adolescents have access to these devices. अपने तो मौलाना फरमाया so I just mentioned that कि 15 बरस ना बच्चाओं cell phone रज़ा न थी. And of course, social media ni भी मौलाना वर्षों पहला फरमाऊँ तो कि ना होए. So anyway, so this is that's my understanding. Please forgive me if I'm mistaken on that. But anyways, cyberbullying, attention fragmentation, and body image, these are risks that come with social media. Potentially more connection with people in their community, people of like-minded interests. So there's a potential benefit, but again, in my opinion, I think the benefits do not outweigh the risks. Ideally, the conversation should be what healthy developmental experiences could we replace with screens, rather than the conversation being no screens. The conversation might shift to what can we do instead of screens. A lot of families or a lot of some people have asked me about what does what can we do, how do we deal with this. This is just some practical tips. So of course, like I said, protecting sleep, maintaining routines, definitely not allowing any devices on the table or tal, that's device free zone, encouraging offline friendships, emotional language, and then normalizing asking for help. I think one of the takeaways for parents should be that a supportive, open communication type of relationship with your teenager and with your child is going to be more beneficial rather than the negative and focusing on shame and trying to force them to do things. Generally, I always say this, when you force somebody to do something, the immediate reaction is going to be, no, I don't want to do that because you're forcing me to do it. So it should be a more nuanced conversation. Hey, I think you're struggling with this. How do we reduce this? I think it's a problem. I don't think it's helpful for you. It seems to be causing you more problems. What can we do to support you for not doing this? We care about you and those types of things. Okay. Substance use disorders. A child is 14. Her parents discover vaping devices in her backpack. She says, "Well, it's not nicotine. Everyone does it." And she also said, "Well, and it's helping me with my anxiety. I get more anxious when I'm not using it." I think the number here is 40%. So the percentage of teens, they actually underestimate that their vape pens have nicotine. There was a study that said, I think it was 41% thought that their nicotine, their vape pen, they thought it was nicotine free, but then they tested positive for nicotine. So they truly may not be aware that they have nicotine in these vape devices. So they're of course especially addictive for adolescents, not just because of the nicotine, but sometimes because of the flavoring that is put in, fruit flavors, etc., colors, and then marketing, in social media, like I said, influencers, these types of things. Like I mentioned before, making it like a more of a shame-based approach that usually will not work long term. When people are using nicotine and then they stop using nicotine, they might experience withdrawal. So when they're withdrawing from nicotine, that itself causes more anxiety, relieved by nicotine. So therefore, the idea becomes, well, I'm anxious, not because I'm withdrawing from nicotine, but I'm anxious. I use nicotine and now I feel better. So that reinforces that addiction. And then healthier coping strategies. Replacing the vaping. Of course there's different nicotine replacement therapies. I don't want to go into too much detail, but gums, patches, lozenges, for example, those are helpful, and so you can talk to your doctor more about that. But this is substance use vaping, adolescents. Again, adolescent brain primed for addiction because the reward system and lack of impulse control. They're more sensitive to new things, peers, risk taking, and social influences. A lot of nicotine in these vape pens. They can also have marijuana concentrates. They're easier to hide, let's say, than a pack of cigarettes and a lighter, for example. The smell is also different, and it's normalized on social media. Sudden secrecy or changes in behavior, new friends, withdrawal from activities. These are warning signs that might get you on the track to say, think about at least, okay, is this a substance user? Maybe they're using something they shouldn't be. Again, open and supportive communication. This is a picture, a couple of years ago, I wasn't sure what vape pen looked like or what these things were. So I thought maybe other people are not sure. These are what they look like. They come in cylinders or cartridges, and you can see how they look very different than a classic cigarette, for example. Okay. Eating disorders, again, Pella mentioned Karuto. Unfortunately, it does start a lot of the times during adolescence, especially for girls. Tahira, 15, becomes super healthy. She cuts out carbs, desserts. She's exercising twice a day, and she's losing significant weight. In fact, her friends are saying, "Well, yeah, you look good. Wow, you're not eating any dessert. You're not having any cake at school, for example. Good for you." So when does healthy eating become concerning? Oftentimes when it's rapid weight loss, and these are early signs as well, but rapid weight loss, when they're very rigid about their food, they don't want to give up their exercise routine even for one day. They're missing social functions, family functions, because either they're going to work out or maybe they're conscious about their food. One interesting thing actually that I had come across, during my residency was a patient, a teenager. She was maybe, I don't know, 16, 17, but she would cook her family's meals. In fact, she would cook them pasta and these types of things, and then she would serve them. And they started noticing that she would eat last, or sometimes she wouldn't even eat. And so it kind of becomes a behavior where you think, I mean, subconsciously you think, oh yeah, maybe they are eating. Oh yeah, we were all sitting down for dinner. She made us dinner. So those types of behaviors, not saying that they're common. I'm just saying that this is what can happen. It's easy to miss initially because we do have a weight focused society, and so when people are losing weight, we often do encourage them. I would just caution that with the age group, of course. So eating disorders in youth. There's restrictive type eating, there's binge eating, there's purging behaviors, which means throwing up, also using diuretics, laxatives. But the most common factor for all of this is dissatisfaction with your body. I Somebody with eating disorders would say, I see my body as this. And you are looking at them and you're saying you're not that. But it in their mind, because of this eating disorder, there is such a big mismatch between how they actually look and how they think they look. These are the warning signs I talked about on the previous slide. And importantly, I know the previous slide was a girl, but it doesn't have to be. Men and boys can also struggle with eating disorders, especially when it comes to like weightlifting, for example. And there's something called muscle dysphoria. So they think that their muscles are should be larger than they are. You can get into like using steroids and injections and these types of, goes on from there. But it can affect boys as well. It is more common in girls, though. Wow. So let's say you have a teenager, or you know of a teenager, or you have a child, and you're worried about what does an emotional crisis look like. On the left-hand side, these are warning signs. And so one of the myths is asking somebody about suicide will increase the risk. So I better not bring it up. It's a subject we don't want to, we don't want to ask them about it, because if I ask them about it, they'll get the idea for it. That's not what research shows. So it's better to have an open relationship, an open, as I said, asking them about it, giving education about it, આપનું જે મૌલાના જે હદિયત આપે આપે છે, ilm આપે છે, those are obviously very important as well, but keeping that communication open. So withdrawal, hopelessness, major mood changes, self-harm behaviors, I've highlighted that one because it's obviously very concerning. Blood and cutting, for example, burning, sometimes hitting themselves. Even not eating can be seen as a self-harm behavior, punishing themselves, the pain, the hunger pangs that they're getting. But that is not always with intent to end their life. It is definitely a sign of emotional distress. And when I talk to patients that have struggled with this in the past, what they've shared with me is that they're experiencing a lot of mental distress, and they're trying to localize it to a physical distress. So I can see the cutting. I can see the blood coming out from where I'm cutting. So in that sense, it helps them focus their distress rather than a lot of distress in their brain. Supportive relationships and feeling connected, access to care, of course, trusted adults and trusted people in their lives, those are all protective things. Sorry. So when to seek help? These are the, again, takeaways for this. Persistent impairment, refusing to go to school, severe mood changes, self-harm, significant anxiety, depression, and also developmental concerns. So we want to try to get into this as early as possible. Um, we know that if we can help somebody as early as possible, get them connected, get them into therapy, medications if appropriate, then that will change the outcome. These are different types of treatments that I've already mentioned. Takeaway again is that it works. There's lots of different types of therapy. So I don't want you to think, oh, the doctor is just saying कि dawa le lo, dawa push karo amar bachao par, dawa, these types of things. That's not what I'm saying. I'm saying that medications have their place, but other types of treatment also are very and equally important. So therapy, parent coaching, the routines we talked about, school programs and supports, those are all important things, healthy routines. And then so it's multiple, it's a lot of different layers. That's what I'm trying to say. Final takeaways: children communicate their behavior, their distress through behavior. We want to get early support, changes their trajectories. We want to have good connection. We want to have supportive relationships with our children, not very strict, authoritarian, my way or the highway type of relationships with our children. We want to have those types of connections. So one thing I want you, if you're a parent, if you're a teacher, I want you to take away, and I want you to spend some time thinking about, if you're so inclined to do so, is imagine there was a child struggling with mental illness. What's one sentence you imagine they would want to hear from an adult, from a caring adult? So, do you think they would do you think they would imagine, do you imagine them wanting to hear, well, I'll let you think about it, but anakaro, 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 this is not right, this is not, those types of, I mean, definitely education has its um, its purpose. But if you had to choose one sentence, how would you approach that with your children? Wow, these are some references. Again, please screenshot Leila Jo. These are different things, places with facts, and then there's different links there as well. So I think I have a few minutes. Dr. Fatima, do you think we have a few more minutes?
Sure.
Yeah, okay. So if anybody has any questions, I'll do my best to answer them.
Sorry, before we get to questions, I just wanted
Sure,
to
sure.
say thank you so much, Dr. Mustafa Bai. It's amazing how you've managed to fit in so many different topics. As you said, it's a really vast topic, and it was a big ask to ask you to go through it. But there is a lot with child mental health that is really important, even to get a little bit of an idea and kind of be aware of it. For for anyone that attended it and felt like they missed any part of it or couldn't take the screenshots, this is live streamed and it is saved on the SBMA YouTube channel. So if you go on YouTube and you type in just the topic that was on the webinar, or you put "Let's talk child health," or Dr. Mustafa's name, it should all come up. And if you can't find the link, just reach out. But it should all be recorded there, so you should have access to it whenever you want. But yeah, thank you so much. There is already a question in the chat.
Sure. Sure. No,
Um,
no problem. Thank you, Dr. Farman, and thank you again for having me. I think I'll be back in August for dementia, so I'm looking forward to that. It's the opposite end of
yes,
the lifespan, but yes, thank you again for having me. And so yeah,
Talia.
there's a question that says, how do world events impact a child's mental state, and what are some strategies to mitigate it? Well, I would suggest that we would be the same, it would be well, similar to how we would advise adults, for example. A lot of world events, हमना सगला ने खबर छे, if you're paying attention to the news, we know everything that's going on, bad things, not great things, the news. And I would say also, sorry, one more thing for child and adolescents as well. A lot of negativity, right? I had a patient who was a younger patient today, and they're looking at their career prospects and they're thinking about their future and they're wondering about the economy. A lot of young people are worried about affordability, especially with home purchases, and so there's a lot of different stressors and a lot of angst that teenagers especially have. My advice would be that there's always two things, right? There's always things that you can control and there's things that you can't control. So I think as their parents and as for me as their physician, for example, I always encourage them to focus on the things that they can control. So there's a war going on, there's famine, there's maybe a new pandemic on the horizon, the housing market might crash. But does that mean that you should now stay up all night, watching YouTube? Does that mean you shouldn't go to school? Does that mean that you should skip school? Does that mean you should, use substances to make yourself feel better in the moment? Probably not, because that's not going to help you long term, regardless of what's going to happen in the world. So I think the encouragement needs to be, focus on your own physical health, on your own mental health, and try to do as best as you can. And that would be definitely something that I would refer, for example, for therapy rather than medication. Medications often wouldn't help that type of distress. Hopefully that's helpful.
And I think the other thing as well, because we've had that question come up a lot as well, with as you said, everything going on in the world in terms of in Palestine, etc. And often, people will say, well, I'm trying to keep my child away from it, but it's everywhere and we can't. And I think it's helpful to also know that, shielding your child might not be the best option, right? So if you
Right.
open up that conversation and have time. So rather than just continuously looking at, Instagram pages or the news that
Sure.
it's just constantly going on, have time set where you talk about it.
Exactly. Absolutely. 100%. Dr. Furman. I 100% agree with you. You've probably heard in your practice, I know I've heard of this term doom scrolling. So the people have even assigned a name to it where they are literally scrolling through TikTok and Instagram and doom scrolling, all these bad things are happening. And anyway, so there's another question that says mental illnesses are categorized into several broad groups. How would you treat or find which one a child or adult is suffering from? So the way that I work is whenever I meet somebody, I ask them what they feel their main struggle is. If they do have a feeling, if not, then I usually have a set of questions that I'll ask them in my mind and a list of questions that I kind of go over. And that's usually hitting major areas of depression, anxiety, sleep, appetite, concentration, excuse me, suicide, of course, and hallucinations and these types of different symptoms that we see in different illnesses. And I'll of course ask them about substance use as well. I might ask them about family history, for example. And so that helps me narrow it down to, okay, I think it might be these types of things. Oftentimes, if somebody is going to see a doctor, they themselves have a problem. They themselves feel like, listen, I'm not doing well in this area, and this is what's bothering me. And so then I can usually prioritize what's the most I can prioritize their treatment plan from that. I don't know if that was helpful or not, but that's how I would figure out what to treat.
While we're waiting for more questions, I just wanted to
Yeah.
also highlight, as you'd mentioned, like SBMA is trying to address a lot of like education and, getting things, people aware and getting these conversations started. So last year, following the Safe Biomedical Association conference, we had a competition, like a Kidmat competition. And so the group that won that competition, they're going to be starting a Kidmat initiative initially in Chicago, and it's actually focused at children who are struggling with ADHD or with concentration and introducing fidgets and things like that in madrasa. And so the aim is that then that will be trialed initially, piloted in Chicago, and then will be rolled out to all Jamaats in North America. So, watch the space, because I think there's a lot of the awareness starts with us, with
Mhm.
madrasa teachers, and then to actually put things in place that helps those children that do struggle, because all children don't focus at the same level.
Yeah,
Um,
I agree. I agree. Definitely, there's definitely a lot of there's this funny comic. I'm sure you've seen it, and I think it's a man sitting at a desk, and there's five or six animals lined up in front of him, and there's a tree behind the animals, and he says the caption is, today your test is going to be there's a monkey, there's an elephant, there's a duck, there's a fish, and he says, today you're going to be tested on how fast you can climb this tree. And so the monkey has a smile on his face, of course, and the other animals all look worried. So to your point, everybody has their own strengths. Even children with ADHD, of course, have their own strengths. And one thing I was going to say, people with ADHD do well in life. They do excel in life. In medicine, they always classically say that people with ADHD are attracted to emergency physicians, for example, emergency medicine, because they love the constant stimulation and the go go go. So they it's not as if they, but it is harder for them to achieve something that somebody with non-ADHD, for example, especially in academic settings, might have. So,
yeah, and there's, as you said, there's a lot of help available, right?
mhm.
I had Momin uh, been in London actually, who had approached me once, and we'd done a mental health talk during COVID, and she said, she was like, I'm so glad this is being brought up, because she said, I have left masjid so often because people will. I can hear people talking about me saying she's not even controlling her children, but she's like, I would come to masjid as an escape because I was so tired and I wasn't able to control them anymore. And no one came to me and offered help or said, look, this doesn't feel like normal behavior. Maybe you should go and see a doctor. And so she's like, when I finally did go to a doctor, he was diagnosed with ADHD, and I finally had a reason for why my children were not paying attention. And she's like, in masjid, like I used to leave and I couldn't go because of that stigma, right? So yeah,
Mhm.
it's
Yeah,
it's it can be difficult.
yeah, yeah. And luckily, I mean, you mentioned the UK, and so I'm a little bit familiar with that system as well. But from what I've heard recently, it's quite difficult to get treatment, get diagnoses. I think they have their own system on how the HMS does it. So I think most places in Canada and certainly the United States, pediatricians, are able to diagnose and treat this. And then, of course, psychiatry is there as well. we'll wait another minute or so. Yeah, Maghrib naj panch minute ma ke thai che, but I have some time.
If anyone wants to unmute and ask a question, you're very welcome to do that as well.
Yeah, the session was recorded. Just yeah, wanted to make sure that everyone knows that, and all these questions and answers will also be recorded as well.
Yeah, I think it seems like there aren't any more questions, but yeah, if there are, Dr. Mustafa kindly put his details. Please feel free to reach out. You're always welcome to reach out to me as well. Um, and yeah, inshallah, we'll see you at the next talk. Thank you so much for attending, and thank you, Mustafa, once
Yeah,
again.
somebody
Yeah,
raised their hand.
yes.
Yes, hi, I'm Fatima from Miss Saga. I just wanted to thank you all for bringing up this topic and talking about it. Like, I'm in the field of early childhood education, and I see in a class of, say, 10 students, there are two who need special attention on an average. So that shows that, like, there's a huge need, and we need to, like, and as you said in madrasa as well, if we can get this incorporated and working on how we can help our children the best. I think it's a great initiative that you all have uh, come up with. Thank you so much for that.
Sure. Thank you very much, Fatima, and thank you.
Thank you.
Thank you, and for your work with early childhood education as well. I know that's not easy, but you're right. And learning coaches, IEP plans, 504 plans, those are all helpful as well as you know better than I do. So I
Thank you,
don't know if
Mustafa.
I don't know if in Canada they call it, something different actually. Maybe I should have looked that up, but here we call it, individual education plan or IEP plan.
Yeah, they are the ISP here. Yes, in individual specialized plans.
Sure,
Yeah,
sure.
right. Thank you.
All right, Chalo. Thank you, everybody. Thank you for coming. I appreciate you all taking the time and coming, and hopefully it was helpful. Also, I was going to say, if there's any feedback for me, please feel free to send that my way or to Fatima Ben. I can maybe incorporate that into my next talk as well on Alzheimer's. If there's any questions about Alzheimer's or dementia as well, please let Fatima Ben know from beforehand, and I can try to focus on that as well. That would be helpful for me personally as well. So, Chalo.